ready.
So she did great. Her left tube was a little bit shorter than her right tube, but not much. Left tube was 6.1 centimeters
Okay.
and excellent flow. Her right tube was 7.6 centimeters and excellent flow. She did have the left ovarian cyst that we saw on the ultrasound.
Mm-hmm.
This is a physiologic cyst, which means just a normal cyst.
Okay.
Went ahead and opened and drained the cyst. The cyst is no longer there.
Okay.
All right. She, on the right side, she had a small amount of endometriosis. I don't know if has she ever been told that she had endometriosis before?
I think that when she was saying she had a DNC and they cleaned out any that they had at the time.
They wouldn't clean it. They wouldn't be able to clean
I
out
don't know.
endometriosis on a DNC, but they may have seen it when they went in there to tie her tubes.
Yeah.
And this was mostly only on the right ovary and the right tube. And so when we see endometriosis, we cut it and burn it off so that we can remove it. We don't want the patient to have endometriosis because it can cause pain and discomfort during cycle. So endometriosis is mostly just on the right ovary and the right tube.
Okay.
We excised it and burned off the little areas of endometriosis, so that's gone. All right. Endometriosis can come back, especially now that her tubes are open, but chances are at her age, she probably won't get any endometriosis in the future, but there is a possibility. So let's see. So left ovarian cyst, drained the IUD. I removed the IUD as well.
Mm-hmm.
Okay. So those are the results, and I'll explain the surgery now. On the average tubal length after a tubal reversal is typically between 5 centimeters to 6 centimeters, 5 to 6 centimeters, because most of the time they don't put clips or rings. They'll usually burn sections of tube, and so this is just the average. So her average is, she's high on the left, and her right's really good.
Okay.
So we typically see longer lengths if this is the uterus and this is the fallopian tube that's coming off of the uterus.
Mm-hmm.
If they just put a clip on the tube, or in her case they pulled the tube up and put a ring around it, then there's usually not that much tube that needs to be cut out, that's been destroyed. And so I normally have longer lengths here and here to put the tubes back together. Whereas in some cases, if they burn the tube, they might burn the tube like this, so that all of this is gone, and now I only have this little small segment here, this segment here.
Okay.
So you typically have longer segments with the types of tubal ligations that she had. All right. The flow, the best flow is what she had, excellent flow. Some patients have moderate flow, some patients have minimal flow, and very rarely we'll have a patient with no flow. The majority of patients are above this minimal threshold. Mm-hmm. So most people either have excellent or moderate flow, and in her case she had excellent flow. And so basically what that means is, if this is the vaginal canal, the opening to the vagina, in the back of the vaginal canal is the cervix.
Mm-hmm.
The cervix goes through the vaginal wall and then enters into the pelvis. And this little cervical canal goes through and opens up into the uterine cavity. And then in the uterine cavity, you've got these little outpouchings that become the fallopian tubes. You've got the ovaries underneath here. So, yeah, before we do the surgery, in her case, I removed that IUD first.
Yeah.
But after I've removed the IUD, I put a little catheter up here into the uterine cavity. It's got this little balloon, and the catheter has an opening so that I can inject dye through this catheter to fill the uterine cavity up, and then we can see how the dye goes through the tubes. In her case, she had the rings, and so what happens is after, basically the tube's been blocked with the rings, all right, so that she's got scar tissue here. And so typically, in order to get pregnant, sperm is deposited in the vagina, swims up through the cervical canal, sperm can get into the tube, the ovary produces an egg eventually. It develops in this thing called a follicle. As the follicle enlarges, usually around 2.2 centimeters or so, the follicle ruptures, you have something called ovulation, and that egg ends up in the tube in many cases. Sometimes it doesn't, but if it ends up in the tube is lined with these little things called microvilli. And this is the lumen, or the hollow part of the middle of the tube. These little microvilli move, and there's fluid in the inside the body, and these microvilli kind of move the current of fluid this way, so that what happens is that egg ends up being just brought in towards the uterus. The sperm has this long flagella, and then it has a head region, and a little neck, and this little acrosome region. This flagella moves, and so the sperm can actually move forward. And so the sperm are moving up the tube, the egg is moving down, and if ovulation results in the egg being released and picked up by the tube, and the egg gets into the tube, and the sperm and the egg meet, then you can sometimes get a fertilized egg if the sperm is able to penetrate through the outer portion of the egg, which is called the zona pellucida. The sperm can get inside the egg, and this fertilized egg starts to divide and develop. And now, because the sperm is inside the egg, it can't swim anymore, so this egg just keeps on getting pushed into the uterine cavity. And it usually takes about 3 or 4 days for this developing embryo. It starts off as something called a zygote, so once it gets fertilized, it develops into an embryo, and by the time it gets into the uterus, this embryo has multiple layers at this point, and it has these cells on the outer part that are called the syncytial trophoblastic cells. And those cells have a specialized way of invading through what's called the decidual layer of the uterus and getting a blood supply into the muscle of the uterus. And if all that works out, then that blood supply will allow a fetus to develop from that little embryo. So a lot of things have to happen for that to occur. In her previous pregnancy, she had said that she had had what's called a luteal phase defect, where there's not enough progesterone to support this implantation and to help that little embryo implant. And so unfortunately in some of those cases you'll have a failed implantation, and it'll result in a miscarriage. But if everything goes well, that embryo will implant, and you end up developing this little fetus. But of course you need the tube to be open in order for the egg and the sperm to get together. So after they've tied the tubes, that can't happen. The egg can't get past the scar tissue, and the sperm can't get past the scar tissue.
Yeah.
So this is what we find in most cases. We go in there and we cut out the scar tissue, and now once we've opened up the tubes, you've got this tube, this inner layer with these little microvilli is surrounded by a layer called muscularis, and that's surrounded by a skin layer or a serosa. So once we've opened up the tubes, it looks more like this, all right, with the little hollow part in the middle with the microvilli. There's something called mucus alpinx, which is a tissue layer that contains the blood vessels that provide blood flow to the tube. And so I have to also trim off this mucus alpinx area that had been scarred up, and we put the mucus alpinx back together. And this basically kind of zips up the mucus alpinx to where it brings this piece of tube here out closer to this piece, so the tubes end up basically being aligned kind of like this now. All right.
Okay.
So prior to aligning the tubes, now that I've got the catheter in place, we fill up the uterus with dye, and there's a certain amount of force which results in something called pressure, and the amount of pressure that it takes to overcome this pressure of this tube is basically how I judge the flow. So if I have to put a lot of pressure, a lot of force, and to inject the dye to get the dye to come out, then the flow is not so good. So if I don't have to push very hard, and so the low pressure, the dye comes out of the tube, and we've got good dye flow coming out of this what's called the proximal tubal segment, then I can say, well, this proximal tubal segment has excellent dye flow, which is her case.
Okay.
And then I'll do the same thing with this, what we call the distal segment. I'll inject a little dye here, see how it comes out, and if she's got excellent dye flow in both segments, then I know when I put the tube back together, we should have excellent dye flow through the reanastomose tube. So in her case, she had excellent dye flow in both cases. Very low pressure. I was able to get the dye to come out of the proximal segment as well as through the distal segment. So once I've put these tubes basically next to each other by closing up the mesosalpinx, I take these very fine sutures, and if this is the other tube, the distal tube is a little bit wider than the proximal tube, because the tube typically, if
Gets
this is
bigger.
the uterus, the tube typically kind of goes out like this. So
Okay.
you have a wider diameter here than you do here. What I'll do here now is I'll take a little suture, a very fine suture, thinner than your hair, and I'll put it on the outside of this lumen here, and I'll say the same thing with the other side, this distal segment, and I'll pull these together. And so I'll start putting the middle portion, this lumen, back together with these very fine sutures, and I'll just go around from the bottom, working my way back up to the top. And so it basically just takes those two tubes, and I brought them together, and now I'm stitching them together very, very finely.
Yeah.
So where you have the tubes completely lined up. Once the lumens are reanastomused, and the muscularis is reapproximated, because now the lumen is attached to the muscularis and it's going to be right next to each other, I go back and I put fine sutures in the muscularis, and we do the same thing to the muscularis as we did to the lumen, and so that brings the muscularis together. And then now I'll just have to close the serosa. And so we start at the mesosalpinx. If you look at this tube, you've got this mesosalpinx right here. So we don't go across. We basically tie the serosa here. We do a running suture all the way across here without interrupting the mesosalpinx that we put back together. And so once this tube is reanastomosed in all three of these layers, then we inject dye again, fills up the uterine cavity, and now the dye goes through the entire tube. It goes through the proximal segment, right into the distal segment, and then out of the end. And then we make sure that her dye flow matches what we had anticipated based on what the dye flow was from the proximal to in the distal segments when we did those initially. And then we also make sure that there's no leaking here at the anastomosis region. And if there's no leaking at the anastomosis and we get our expected dye flow, then we measure this tubal segment once it's been put back together, and her left again was 6.1 centimeters. Then we go to the other side and we do the same thing on the other side. In her case, she had a little bit of endometriosis on the bottom of this right ovary. And she had a little bit of endometriosis at the salpinx, the mesosalpinx, where it basically intersected with the scar tissue on the tube. So we went ahead and cut that away and just bladed the little areas to make sure that there isn't anything that comes back there. And then we did the same procedure on the right side as we had done on the left side.
Wow.
So does that make sense?
Yes.
Okay.
Thank you.